Okay. As we've said, today we're going to talk about the making medical decisions and making those decisions. Well, and of course, I'm not making those decisions when a dementia diagnosis is in the picture. And where do we start? Do we look at things differently? And if so, how do we look differently? You know, as we age, we're faced with more and more medical diagnoses and consequently more decisions to make about our health. And each of these generates its own set of questions about what to do next. There's then, aside from the diagnoses, there's the general expectations that we lead a healthy lifestyle, that we eat well, that we exercise, that we have social engagement, and those routine screening tests that we're asked to get to spot any abnormalities early. These screening tests, however, frequently lead to need for additional screenings or procedures, including surgeries. Testing, the addition of or changes to medications, treatments, perhaps even surgeries, all of that can become quite a challenge to do, even if we're healthy and we want to do everything possible to keep ourselves that way. When you add a dementia diagnosis, however, it makes this picture even more difficult to figure out and in some ways more challenging and in some ways downright impossible to sort out. So how do we know what's really important and what has little or no value when it comes to these medical procedures and medical care? So today we're going to talk about ways to approach identifying what's most important to your person with dementia and to getting answers and information to the questions that you may have when dementia is in the picture. So aside from those general things I've just said, why do we talk about this topic at all? First of all, there are physical changes that occur as we age. I dare say most of us, especially if you're a spousal caregiver, you're probably very aware because you have gotten to that age where there are physical changes that are occurring. But aside from the things that are obvious, there are changes in both our liver function and our kidney function as we get older. Both of those organ systems are responsible primarily for eliminating the byproducts of medications from our body. So if they aren't working as well, then those byproducts don't get eliminated as well. And one of the things that can happen is that we end up with more medication in our system, even at the same dose that we may have been on for years. Not only does this set things up so that we can have more side effects from that medication, but it also makes a difference in interactions with other medications and the side effects we can have from those. For example, you may have been on the same blood pressure medication for years, and all of a sudden it's making you dizzy because your body's not functioning in the same way. Dizziness then leads to falls, and falls can be pretty catastrophic for anyone, particularly those with dementia. Another reason that we talk about this topic is that medical treatments and guidelines are typically developed by specialists in whatever area that the guideline relates to. And so they are disease specific. They don't look at what happens when a person has more than one disease and how this may interact with each other. And that's particularly true when we talk about dementia. There are almost no medical studies out there that talk about various treatments where there are multiple other kinds of diagnoses of medical conditions with dementia as an overlay on all of that. As medical care becomes more complex, we frequently see multiple physicians who are specialists in their field. And not only do those specialists sometimes not communicate with each other, but when they're looking at treating, they're looking only at the disease that they're a specialist in. So there's a lot more risk of having conflicting information or conflicting treatments as we have more and more diagnoses, and then with the overlay of dementia. The other reason we need to talk about this is that the number of coexisting diseases, what's called comorbidities, increases with age. Comorbidities also then interact with dementia in a way that causes challenges in medication management and may cause acceleration or exacerbations of those other diseases. It's unclear what these increased problems come from when there are multiple diseases, whether they come from an interaction of one disease with another, or they're the result of the impact of the dementia on diseases. But it makes sense intuitively if dementia is affecting brain function and your brain controls everything in your body, that you then would have some differences in the progression of other diseases when dementia is in the picture. What we do know is that there's some research that specifically supports the fact that chronic conditions such as cardiovascular diseases can affect people with dementia to a greater extent than they affect people without dementia. So what kinds of diseases and other diagnoses are we talking about? 70 to 90% of people with dementia have at least one other medical diagnosis or comorbidity. 61% of people with dementia have at least 3 other diagnosed conditions. And actually, the average number of coexisting conditions with dementia is 4.6. And this may be an underreporting because people with dementia frequently cannot complain of problems or fully express what issues they're having. So there may be underdiagnosis of conditions that are occurring along with the dementia. What do we usually see as the most common comorbidities? Diabetes, cardiovascular disease, including high blood pressure, stroke, heart failure, atherosclerosis, which is the buildup of fats and cholesterol and other substances on artery walls, and infections. The other things that we frequently see co-occurring with dementia are bladder control problems, osteoporosis, sleep issues, and weight loss, just to name a few. The other reason that we need to talk about this topic is that the goals of care may change when dementia enters the picture. What's important through our life changes anyway. For example, when we're teenagers, our primary concerns are school, at least we hope, and relationships with peers. As young adults, we make lots of decisions, including medical ones, based on financial concerns and probably a desire to spend time with our children or other members of our family. As we age, we make decisions that support what we are most important at that time, which may be spending time with your spouse or traveling, things that you haven't gotten to do to the extent that you would like earlier in life. Hopefully, all of you have had an opportunity or will have an opportunity to talk directly with your loved one about what's important in terms of their overall goals for care. If you are the healthcare power of attorney, though, for your loved one, and they can no longer have this discussion because of cognitive decline, you'll need to use your best judgment and knowledge of that person as a basis for making medical decisions. Regardless of the stage of life we're in, or whether we're articulating goals for ourselves or for another person, we have to think about what we value most as we look at setting up those goals and telling others what they are. In general, goals of care are kind of the overarching aims for medical care for a person that are informed by that person's underlying values and priorities, and that are established within the existing clinical context and used to guide decisions about the use of or the limitation on specific medical interventions. If we divide the goals of most people into three big categories, they're usually maintaining function, being able to get around, do what I want to do, making sure I'm comfortable and free from pain, and prolonging life. And what we see is that throughout much of life, those three things are pretty much balanced on a continuum for us. However, once dementia enters the picture, some things may hold more weight as far as medical goals and priorities. One might be comfort. That may become much more important than longevity. And sorry, that just couldn't get there. That may become much more important than longevity and maybe more important than function. We may be willing to not obsess so much about function if in fact, or give up some things if in fact we can be comfortable in that process. In general, goals of care should be based on our values and our priorities, the big picture of the current health situation, how a specific test or treatment or other intervention will help us to achieve those values and priorities and goals of care. They should never be based on just medications or treatments that may be available, nor just about how one wants to die, because in fact, we're all living up until the moment that we die. And they aren't static. Goals of care change over time with the progression of any illness. If we're thinking about goals of care, there's some questions we can ask, and these are worded as if you were answering them, and you may in fact have to be answering them for a person with dementia, as I've said before, if they're not able to do this. However, think about these in terms of your own life, and it may help clarify some things about the person with dementia or help you find ways to ask these questions if they're still able to answer any of them. What gives your life meaning? How would you describe a perfect day for yourself? Who would be there? What would you be able to do? What would you want to experience? Being outside, being inside, hearing music. Lots of ways you can answer that question. What experiences have you had with a family member or a close friend whose health was declining or who died? What did you learn from that experience? Frequently, we learn what we want and don't want from watching what someone else goes through when certain decisions are made. Is there care or medical intervention that you would absolutely find unacceptable? So we've asked those questions, and now we need to work with our healthcare provider. And the little picture up in the corner of the screen reminds us that we're all part of the same team in providing this care. Remember that you are the team leader, you are the person in charge, but that you're using input from all the other people on the team to make decisions. So what do we need to make sure that the healthcare provider knows? Make sure that they understand your priorities for care, or the priorities of care for your loved one. Get as much information as you can about any recommended tests or treatments. Ask questions that specifically get at the difference between the risk and the benefits. What are the trade-offs of these medications or this medication or these procedures? Speak up if your treatment plan is too complicated to manage. I think one of the best examples of this occurring is in people who are diabetic as they have dementia and get further into the dementia process. The control of diabetes demands a lot of self-discipline. You can eat certain things, not eat other things, eat in certain amounts at certain times, have to monitor blood sugar, may have to take medications based on that blood sugar. And that can absolutely become too complicated to maintain when the person with dementia is unable to make most of those decisions or do those things on their own. And you, as the caregiver, feel like you're constantly bugging them, and worse yet, perhaps getting into, shall we say, unfriendly discussions about things like what food they can eat and not eat. Let your healthcare provider know immediately if a treatment doesn't seem to be working or is causing problems. Sometimes this is difficult to do for the reason that I alluded to earlier. It's difficult to identify that a treatment's causing problems, again, because the person with dementia may not be able to help us by describing what's going on or what they're feeling, or at least not in enough detail that we can be sure. Make the most of treatments that cause the fewest or no side effects. Such things as taking a walk, exercising, and other pleasant activities will often go a long way to alleviate stress, and perhaps not just your own stress, but the stress of the person who has dementia. When you're getting ready for a visit with your healthcare provider, here's some things you need to think about. Make a list of the 2 or 3 most important things that you want to talk about at a visit. I think all of us have left a doctor's visit and gotten maybe not even all the way to the car before we went, oh, I forgot to ask about so-and-so. It's also important that you try to limit and figure out what's most important to talk about at a visit, because as we all know, healthcare providers have limited time to spend with you. It's unfortunate, but it is a reality in today's world. Pat made a suggestion this morning that I think is very helpful. Sometimes as a caregiver, you feel so overwhelmed that narrowing what you are concerned about down to 2 or 3 important things is almost impossible to do. Bring in another family member or a friend, someone who knows your situation, knows the person with dementia if at all possible, and discuss before you go for a visit. Talk through what's bothering you, what are you concerned about, and that person may be able to help you consolidate concerns into 2 or 3 things. Or sometimes, if you're like me, just saying those things and saying them out loud, by the time I finish that, I can say, oh, now I know what I need to talk about. Bring all your medications, whether they're prescription or over-the-counter, particularly over-the-counter, because we often forget to ask about those to a visit. If you don't bring your medications, at least bring a list of all the medications. At one point in time with Roy, when we were making some adjustments to medications for various reasons, I added to his medication list not just the medication and the dosage, but I added a column that said when the medication started or if we had stopped a medication, because sometimes that history is really important to have as decisions are being made also. And it's very difficult to remember those specifics when you're in the middle of caregiving. I also added to the back of the sheet on which I had his medications printed all of his medical diagnoses and when each of those diagnoses was made, because frequently I was asked questions about that. And again, sometimes that's really important to know and very difficult, at least for me, and I think for most caregivers, to remember the specifics, especially for things that have been diagnosed for a number of years. Bring some way to take notes with you, while you're in the visit. And the best way to do that is to ask a family member or a friend to come along. Not only can they help you take notes or take notes for you during a visit, but they can help you remember what questions you want to ask or clarify responses to questions that in your, again, the stress of the moment and trying to take care of everything, you might forget. Having someone there to take notes also means that you'll have access to information that you may have forgotten about during the visit because you're emotionally involved in the visit. Sometimes those printouts you get that automatically at the end of a visit that go through a little bit about what you've talked about and what to do next are done in detail and are very helpful. Many times they don't tell you anything you didn't know before you walked into the visit. So taking your own notes and relying on that, what you see in those is really important. So what questions do you need to ask if a new medication is being suggested or there's a suggestion for a test or a procedure that needs to be done? First question is, does this person really need this test or procedure? What are the risks and what are the possible side effects of doing this? Are there simpler, safer options to address this issue? What happens if I don't do anything? And to me, this is a pivotal question that we frequently don't ask. We might ask, well, what else is available, or is there another way to do this? But we frequently don't ask, what happens if I just don't do anything at all right now? And in today's world, of course, many times we do need to ask the question of what's this going to cost and will my insurance pay for it? Remember that the answers to these questions will help you form the basis for making a decision, but that your decisions about intervention will change from time to time as the dementia progresses. What I want to do is take a minute and give you some examples of differences, some of which are simply related to differences in recommendations based on aging, and some that also have a dementia overlay or consideration in them. But let's look at the screening for cancers. All cancer screenings are associated with short-term risk. Anything you do has some risk to it. One of the risks of screenings is what's called in medical terms overdiagnosis, which means that you're diagnosing a condition that's unlikely to cause symptoms or problems during a person's normal life expectancy. So you may, in fact, have a diagnosis, but during the life expectancy of the person with dementia, it may not make a difference in their physical health. Most of the recommendations for routine screenings are based on studies of people who are less than 65 years of age, and certainly based on people who do not have dementia. In fact, most people who have a diagnosis of dementia are excluded from most studies of routine medications and procedures. For breast and colorectal cancers, 1,000 people would need to be screened to prevent one death in 11 years. Now, be careful how you interpret that. For people who are young and have a life expectancy of 20 or 30 years, that one death in 11 years can make a very significant difference. For someone who's much older and is in the moderate stages of dementia and probably has some limitation on their lifespan related to that, that may not be a screening that makes sense for them to undergo, especially with the prep that's required for colorectal cancer screenings. For lung cancer, screening of 1,000 people would avoid 4 lung cancer deaths in 6 years. Of those 1,000, 273 would have an abnormal result. And of those, 36 would then have to get some type of invasive procedure to go to the next step of diagnosis. And of those who got the procedure, 8 would then have some type of complication. Another thing that's routinely prescribed are medications to lower cholesterol and triglycerides, or statins. This study looked at the use of statins over time and over age, and it's one of several that have similar results, but I'm just using one study to cite this information for you. And it looked at the time between, for a person between the ages of 50 and 75, how long did they have to be on a statin to prevent a first major adverse cardiovascular event, such as a heart attack. And there's different information for this if someone has already had a cardiovascular event. So this is someone who hasn't had a heart attack, hasn't had a stroke. How long do they need to be on a statin just based on cholesterol levels in order for there to be a benefit? And what this study and others have found is that the time to benefit from a statin was at least 2.5 years. In addition, side effects from statins can be pretty significant, the most common being pretty excruciating muscle pain in a lot of people, and they often occur in the first couple of weeks of starting therapy. So the bottom line is that statins being started is likely to do more harm than good in a person whose life expectancy is less than that 2.5 years. Type 2 diabetes. Lots of people, lots of adults have type 2 diabetes. It's become very endemic in our population as the population ages more, and related to decreased physical activity and the kinds of diets that we have, and the fact that we tend to be heavier as a population. Typically, the target for hemoglobin A1C, which is the blood test that measures blood sugar levels over a 3-month period of time, is less than 7. However, if you're looking at reasonable targets in older adults, the recommendation is that the hemoglobin A1C be between 7.5 and 8 if they have several chronic conditions and a life expectancy less than 10 years, or between 8 and 9 if there are multiple other chronic conditions and even a shorter life expectancy. There's no evidence that using medication to achieve a tight control of blood sugar is beneficial in most older adults. More potential harm comes from blood sugars being too low, which frequently cause someone to pass out or to fall, than from blood sugars being too high. I want to caution you as you think about the 3 things that I've talked about in these last 3 slides, to understand that every decision about medical care has many, many factors that have to be taken into consideration. And you need to ask questions and find out what those factors are for the person you're caring for in order to be an informed decision maker. These examples are just to raise your awareness of the things that change, that may change with age alone, and certainly with the dementia diagnosis on top of that, that makes some kinds of control of disease entities much more difficult. The bottom line in all of this is that once dementia is in the picture, it needs to be the lens through which we look at everything else medically, whether that's medications, procedures, or surgeries. That we've got to think about the impact on dementia as we make each of these decisions, or the impact that dementia has on the management. One of the things that during Lent this year that we've had as a theme for sermons has been living life in the messy middle. When you're a dementia caregiver, a lot of your life, and the decisions you are called on to make are in that messy middle. So think about that. We often think there's one right answer, there's one wrong answer to every problem, but the reality for all of us is that much of our life, whether it's medical decisions or otherwise, is lived in that messy middle where there is no right answer, but the need to look at all the factors that may be involved when we make a decision. This slide, these are some helpful calculators that I found that you may be interested in looking at. I'm going to see if I can go to one of them. Okay, this is one that talks about time to benefit, between how long does it take if you've got an intervention and how long is it going to take for it to be of benefit. And let's just look at someone that this is their life expectancy. You know, you're moving their life expectancy over to whatever it is, whether that is a shorter life expectancy or a longer life expectancy. And if we're looking at mammogram, when we get over here to longer life expectancy, you can see that there is a lot of benefit to that. If we've got shorter life expectancy, then we're way over here in this area that's not very helpful. This also looks at blood glucose control, blood pressure control, again, the statins that I've talked about. So there's several other things that you can look at this, and it will give you some idea how long it takes to benefit from that particular intervention. So that's something you may want to look at just to give you some ideas. This is a list of other resources that you might find helpful. The first one in particular, the Health in Aging website, has lots of documents on it that help you learn what might be appropriate treatments and interventions and what questions you need to ask about them. One of the documents that's on that website is a document that was developed several years ago by geriatric physicians, or those physicians who are most trained to deal with the aging population. And it lists 10 things that you should ask questions about if they're recommended as interventions or procedures for your loved ones. And under each one, it will give you a little bit of information about why that recommendation was made. And on this particular website, under multiple ones of those 10 things, it also gives you links to additional information about why they are encouraging you to make certain decisions in that process. So I think all of these are helpful, but the one that I listed first, I think, is particularly helpful. So the bottom line is, as I said, we're all living in the messy middle. None of the decisions we make are easy. Many of them are things we never have thought about as we made decisions, or as we think about the dementia. I thought about lots of things when Roy was diagnosed. What would I do if this happened, and what would I do if that happened? Didn't think about what would I do if he fell on the concrete and had multiple skull fractures. Didn't think about what I would do if he had a stroke. Didn't think about what I'd do if he had a heart attack, yet all three of those things happened. So we can't anticipate everything, but knowing what's important to our loved one and knowing what we can know about possible outcomes and asking questions as we go along about procedures and medications and tests does make a whole lot of difference in our being able to decide what those goals of care are and how they're balanced against each other in this process.